Yesterday we had one session. Now we are continuing the NNF Karnataka State Chapter web series. Today I've got two important topic. The best part is throughout the series, the topics which has been put are all very relevant and very practical oriented and practice oriented for neonatologists, both who are practicing in the cities and even in the rural areas. So today's topic is something which is universal, that is common neonatal problems what we come across in our day-to-day OPD practice. Plus, we have another topic on birth trauma, which we come across, especially if there is a big baby and we have issues like clavicle fracture, Erb's palsy, brachial plexus palsies, and the cut, the hematoma. So many good the routine neonatal problems what we come across in our practice. So for today's session, we have got two young and dynamic speakers. To start with, we have Dr. Shridevi. Dr. Shridevi, on behalf of NNF Karnataka State Chapter, we would like to give a warm welcome on behalf of our entire office, President, Vice President, Joint Secretaries, Executive Board members, and the entire NNF Karnataka members. A warm welcome to you, Dr. Shridevi.
Thank you, sir. Good evening, one and all. So I thank. Can you hear me, sir?
Yes. I request you to give a brief introduction about yourself, and then you start the session.
Yes, sir. Yes.
You, Dr. Shridevi.
First of all, I thank Prashant sir, Dinakar sir, Kotaresha sir, and NNF, all members and committee people for giving me this opportunity again to present in this web series. So I'm Dr. Shridevi. I'm a consultant neonatologist at Manipal Northside Hospital. For today's session, I've been given a topic, birth traumas. So whenever we are called to attend a delivery, either a section or vaginal delivery, sometimes it becomes a assisted vaginal delivery with the use of forceps or vacuum. Always we need to keep in mind that these neonates are always at some risk of having birth injuries. So as a pediatrician, we need to have a complete knowledge about these birth traumas, their course, evolving course, the clinical spectrum, prognosis, and treatment. So some of the birth traumas which we encounter in a daily practice, I'll be covering in this session. So I would be discussing definition, classification. In classification, again, we have a soft tissue injuries, some of the extracranial injuries, intracranial injuries, neurological injuries, and some fractures. So what do you mean by birth injury? Birth injury, it is defined as a structural destruction or functional deterioration of a neonate's body due to traumatic event at birth. So it can vary from minor injury to severe injury. It has got a broad spectrum, which is associated with significant morbidity and mortality. So almost 2% of singleton vaginal deliveries encounter these birth traumas, and nearly 1.1% for cesarean deliveries. So there are various risk factors. Like the first most important one is macrosomia. That is, the weight of the baby more than 4 kgs are at increased risk of having this birth trauma. So the degree of risk changes with the degree of macrosomia. For example, if the baby is weighing more than 4 kg, or if it is between 4 to 4.5 kg, there is almost twofold increase in the risk of having birth trauma. And if the weight is between 4.5 to 5 kg, then the birth trauma the risk of having birth trauma increases by 3 times. And if baby weighs more than 5 kg, then almost 4.5 times we see the baby will experience the birth trauma compared to any other babies. The second important risk factor is the maternal obesity. So with the mothers who have BMI of more than 40 kg per meter square, these mothers, maybe because of increased use of instrumentation, or sometimes they have babies who are large for gestational age. In that case, they experience shoulder dystocia and more prone to have a birth trauma. The next is the abnormal fetal presentation. So most commonly we see the babies who are delivered by vaginal route of delivery, especially the breech infants, they have more morbidity. The systematic review published in 2015, Cochrane review, in that when they have compared cesarean deliveries versus vaginal delivery for the delivery of breech infants, they saw that the cesarean delivery actually reduced the morbidity associated with breech infants. The rate of birth injuries for infants with breech presentation born by cesarean delivery without a trial of labor was 6 per 1,000 live births and 10 per 1,000 live births. And by vaginal delivery, it was 30 per 1,000 live births, as this was published by Lyons et al. This study was conducted in Canada from 2003 to 2011. So when they looked at the statistics of the injuries associated with variety of the use of vacuums, forceps, or a cesarean, and they compared the birth trauma in each of these groups, and they found that forceps and vacuum, as you can see here, which is marked in red, these babies had higher incidence of birth trauma as compared to spontaneous or cesarean deliveries. So always there is a debate which is better, cesarean delivery or vaginal delivery, or which is protective. The answer is still unclear, but there are several studies which have been published. But one of the study is published in 2010 in American Journal of Obstetrics and Gynecology. They said that in this study, they used the analysis of healthcare cost and utilization project nationwide inpatient sample scores, and they found that the birth trauma had almost reduced with cesarean deliveries. But when they used AHRQPSI scores in these for analysis, which excluded some of the injuries like clavicle injuries and brachial plexus injury, they found that actually vaginal delivery had lesser trauma. So it is all controversial. It depends. The risk varies between cesarean and vaginal delivery depending upon the type of birth. So there are various risk factors for birth trauma which I have discussed already, like forceps deliveries associated with facial nerve injury and vacuum extraction, which can lead to depressed skull fracture and subgaleal hemorrhage. Sequential use of forceps, vacuum forceps. In these cases, babies are more prone for cephalhematoma, intracranial hemorrhage, shoulder dystocia, retinal hemorrhage. And breech presentation, these babies are more prone for brachial plexus because of traction applied on these babies while delivering the head. Intracranial hemorrhage, gluteal lacerations, long bone fractures are most commonly seen in breech presentation. Baby being big, they can experience shoulder dystocia, clavicular or rib fracture, cephalhematoma, caput succedaneum, and abnormal presentation. For example, it could be a bro presentation, face transfers, or compound presentation. They will have excessive bruising because of abnormal presentation, and also the pressure exerted while pulling the baby. They can lead to retinal hemorrhage, laceration, ecchymosis, and so on. Prematurity also is one of the risk factor for birth traumas, where they experience bruising, intracranial, extracranial hemorrhage, which is having very much impact on their outcomes. Precipitous delivery also can cause bruising, intracranial, extracranial, and retinal hemorrhages. So there are a variety of classification for birth injuries. I will be discussing certain topics under these headings. In soft tissue injuries, we have abrasions, petechiae, ecchymosis, lacerations, subcutaneous fat necrosis. In head injuries, caput succedaneum, cephalhematoma, subgaleal hemorrhage, intracranial and extracranial injuries, and subconjunctival retinal hemorrhage in facial injuries. In cranial nerve injuries, we can have facial palsy, spinal cord injuries, facial nerve injuries, which includes a neonatal brachial plexus injury, which is very important, and vocal cord palsy. fractures that can involve clavicle, long bones, skull, and intra-abdominal injury involving liver, spleen, adrenal hemorrhage, and renal injuries. So most commonly what we encounter is aberration in almost all babies we would see this aberrations. It is mostly because of forceps application and dystocia, that is the abnormal presentation of the baby. These injuries are almost always self-limiting. They usually don't harm the baby and do not require any treatment. Next is laceration. Laceration may result mainly by scalp cuts while delivering baby by section or
Shridevi ma'am, can you unmute yourself? Yeah.
The most common sites where we see scalp for the lacerations are scalp, gluteal region, and thigh. So the lacerations are most commonly, as I said, it is seen in assisted deliveries and emergency LSCS deliveries. It can be mild, which involves only skin, and moderate if it involves skin and muscle layers, severe if it involves skin, muscle, bone, and nervous tissue. So the treatment would be, if it is superficial laceration, you can just put adhesive tape to initiate the bleeding, to initiate the process of healing and control bleeding. If it is deep, then you have to suture the laceration. The another birth trauma what we encounter is petechiae. Petechiae are the petechiae may result from rupture of small vessels in the skin. That is because of a tight nuchal cord which is constricting the neck, and precipitous deliveries, breech presentation. All this can lead to petechiae. Now, what we have to keep in mind is whether these petechiae are due to the birth trauma or it is arising from infection. So we need to look at the platelet count to differentiate between the traumatic or petechiae due to infection. So petechiae due to infection, there is no specific treatment for this. It may take few days to disappear. Now, ecchymosis and bruising, most commonly seen in preterms than term babies, usually seen in breech deliveries. If it is extensive, then look for occult sites of bleeding. Sometimes, if the ecchymosis are extensive, there might be a hidden subcapsular hepatic bleed or a splenic laceration, etc. So this ecchymosis usually resolves in 1 week, and also we have to keep in mind that in after 2 to 3 days we need to do a bilirubin in these babies to rule out hyperbilirubinemia, because as these ecchymosis contain blood and lysis of which leads to jaundice in babies. The other soft tissue injury which leads to this is subcutaneous fat necrosis. Subcutaneous fat necrosis is a circumscribed hard erythematous lesion, which is usually flesh colored or sometimes blue. You can see in the picture here, usually seen on the back pressure areas. This is due to paniculitis, most commonly seen in term babies or post-term babies. Sometimes we do see it in cooling, therapeutic cooling. This the subcutaneous fat necrosis occurs mainly because of the focal pressure and ischemia to the adipose tissue within the subcutaneous space. It usually resolves within 6 to 8 weeks without any treatment. But one thing we have to keep in mind is we need to monitor for hypercalcemia, which may last up to 6 months. Because in this subcutaneous tissue, there might be paradoxically.
Hello, ma'am. Yeah.
Paradoxically, there can be increase in 1-alpha hydroxylase enzyme in this subcutaneous fat necrosis, which actually increases the absorption of vitamin D and calcium levels, and which will increase the calcium levels leading to hypercalcemia. So we need to monitor for hypercalcemia in these babies. So next important birth trauma is cranial injuries. In that we have extracranial and intracranial injuries. So we all are familiar with the layers of scalp, this which we see a mnemonic as scalp, SCALP, the layers of the scalp which we had studied in our first year MBBS. So the S stands for skin, C stands for connective tissue, A aponeurosis, L loose areolar tissue, and P periosteum. So the collection of blood or fluid in any of these layers due to injury has been given certain names. For example, if there is a collection of blood or fluid in the layer of the scalp, it is called caput succedaneum. And if the collection of fluid, if the collection of blood in the layer of the cranium, that is in between the aponeurosis and pericranium here. The aponeurosis and pericranium, this is the collection, and this is called subgaleal bleed. And if there is a blood collection below the periosteum, that is subperiosteal collection of blood, that is called cephalhematoma. The difference between cephalhematoma and subgaleal is the most dangerous is subgaleal bleed, where this is because of the bleed of the bridging veins in the loose areolar tissue. And sometimes this bleed can extend from supraorbital ridge up to the nape of the neck and laterally till the ear because of the loose areolar tissue, and it can accumulate blood as much as more than 200 ml. So always we need to keep monitoring the head circumference of the baby immediately after birth if you notice a subgaleal bleed. So 1 centimeter increase in the occipitofrontal diameter in head, the blood accumulated is 1 centimeter is equal to 40 ml of blood in the loose areolar tissue of the scalp. So it is very much dangerous. So we need to monitor for shock also, pallor, anemia, tachycardia, and we need to resuscitate the baby. Whereas cephalhematoma, it's a collection in the subperiosteum. So periosteum actually will not allow blood to cross the sutural line. So it is localized to one side of the skull. The caput succedaneum is usually the self-limiting birth trauma, which will get absorbed by about 24 hours. This can cross sutural line. The complication of this caput succedaneum is it can get necrosed and can lead to infection sometimes, which is very rare. And the presenting part, which where there is a prolonged engagement of fetal head, can lead to a alopecia in that area, in a circular area where the caput is present, and can lead to alopecia, and this alopecic ring is called haloscalp ring. So next, cephalhematoma, as I said, it is a subperiosteal collection of blood which will not cross the sutural line, which is seen in 1 to 2% of all deliveries, most commonly with vacuum or forceps assisted delivery. This will take several weeks to resolve, maybe sometimes up to 2 weeks. Like subgaleal bleed or any ecchymosis in cephalhematoma also, we need to monitor for hyperbilirubinemia, which can manifest after 1 to 2 weeks. So we need to keep these babies on follow-up. The complication of cephalhematoma is it can get calcified and ossified and can change the shape of the skull, leading to plagiocephaly. And sometimes it can get infected with E. coli sepsis and can lead to osteomyelitis and needs incision and drainage and antibiotics for longer time. These are all rare complications. The next is the subgaleal hemorrhage, which I've already discussed. The mortality I would like to highlight here is mortality, which takes about 12 to 14%. So we need to be very careful about subgaleal bleed. The management here would be resuscitation, like if baby goes into shock, manage the hypovolemia. So monitoring in subgaleal bleed is always important. Vitals monitoring, serial measurements of hematocrit, head circumference. Coming to intracranial injuries, the incidence of these intracranial injuries varies from 5.1 to almost 6 per 10,000 live births. The risk factors already mentioned: forceps delivery, vacuum extraction, precipitous delivery, prolonged stage of labor, macrosomia. Usually the presentation would be within 48 hours, 24 to 48 hours. The most common symptoms what we see is apnea, seizures, lethargy, encephalopathy. So these intracranial bleeds could be external to brain, that is epidural, subdural, and subarachnoid. The bleed can be into the parenchyma, into the cerebrum or cerebellum, or it can be into the ventricles, that is usually subependymal germinal matrix or choroid plexus bleed. Now, as you can see in this picture, so the epidural hematoma, you can see on the left side. So this epidural hematoma, the blood is collected between the inner table of the skull and above the dura mater. So this is in the shape of lentiform shape bleed. This is most dangerous bleed because it bleeds from the middle meningeal artery. Though it is rare. Why it is rare in newborn? That is because of absence of middle meningeal artery groove, which is present in older children. So that is absent and in newborn. So it is not easily caught while drawing, while delivering the baby. So often this epidural hematoma is accompanied by skull fracture. It is usually located in parietal or a temporal region. The symptoms, as I mentioned, baby can have hypotonia, seizures, apnea, raised ICT depending on the site of bleed. The diagnosis would be CT scan or MRI. Ultrasound also can help, but it's very difficult to differentiate from other types of extracranial bleeds like subdural. Subdural and epidural cannot be made out so easily on ultrasound. This epidural hematoma can deteriorate very fast because of arterial source of blood, and therefore infant should be monitored very closely. Now the treatment would be, if the lesion is very small, we would manage conservatively and watch for symptoms. If the lesion is very large, then or if there are any signs of raised ICT, or if there is associated depressed skull fracture, then we would go for a surgical evacuation of this hematoma. So the next is subdural bleed. The incidence of subdural hemorrhage is around 2.9, that is 3 per 1 lakh spontaneous delivery, which doubles with vacuum and forceps use, 10 times if both are used. Here the bleed, as I already said, it is between, here you can see it is here it is below the dura mater and arachnoid mater. Here the source of bleed are venous sinuses and the bridging veins. So this is the most common intracranial hemorrhage, that is subdural hemorrhage. Most common location is in the interhemispheric or tentorial region. So in this MRI picture, you can see there is a subdural bleed here, and the red arrow is showing you the dura mater. The red arrow, what we see here is the dura mater, and below the dura mater, what we are seeing is the subdural bleed. And we can see there is a midline shift here. So this is the indication for surgical evacuation. So symptoms I've already described: respiratory depression, apnea, seizures, and neurological dysfunction. Can use ultrasound or CT, MRI to diagnose the bleed. Now, the management depends upon the location and extent of bleeding. Most closure observed without surgical intervention.
Ma'am, please unmute.
We need to focus on treating hypovolemia, correcting coagulopathy, anemia, and surgical evacuation in this case, as I already said, if there are any signs of raised ICT or associated with fracture, then you need to do a surgical evacuation. And if there is a blood collection in the posterior fossa, that is also indication for surgical evacuation, because this can lead to brainstem compression. Now, subdural hematoma in posterior fossa can lead to death because of compression of the respiratory centers.
Sing mute all.
Ma'am, unmute yourself.
Yeah. Now, the treatment is correction of coagulopathy and cardiopulmonary support. Neurological consultation if there is severe hemorrhage, brainstem dysfunction, or hydrocephalus. The next most common subarachnoid hemorrhage is the subarachnoid hemorrhage after the subdural hemorrhage. Here it is mainly because of bridging veins and leptomeningeal vessels. The risk with vaginal delivery is 1.3 and 2.3 with vacuum deliveries, and 3.3 per 10,000 with forceps delivery. The presentation can vary from 24 to 48 hours, presents with apnea, respiratory depression, seizure, and the diagnosis would be by CT and MRI. Treatment would be, we would treat conservatively. Surgical evacuation is done only if there are signs of herniation. And the most important complication of subarachnoid hemorrhage is the post-hemorrhagic hydrocephalus. So we need to monitor these babies who had subarachnoid hemorrhage. Now, the rarest hemorrhage is intraventricular, especially in term babies. Though we see preterm hemorrhage intraventricular common, but in term babies, the intraventricular hemorrhage, it's usually grade 1, that is subependymal bleed, which resolves spontaneously without any long-term implications. Now, the next injury is facial injury, where we see a subconjunctival hemorrhage, retinal hemorrhage, and nasal septal dislocation are the most common facial injuries. So the subconjunctival hemorrhage you can see in the first picture, which we see very commonly. This is because of the rupture of small vessels in the conjunctiva, which usually resolves by 1 to 3 weeks. Now on the right side, what we see is the retinal hemorrhage, which usually resolves in a week of time. So the retinal hemorrhage are usually seen in 75% of vacuum deliveries, 33% of spontaneous deliveries, and 6.7% of cesarean deliveries. They can be seen up to 3 to 4 weeks. We need to worry on retinal hemorrhage only when it is associated with optic nerve injury, which can lead to visual impairment. And other ocular injuries, what we see is a rupture of Decimet's membrane of cornea, lid laceration, hyphema, vitreous hemorrhage, Purcher's retinopathy, corneal edema, and corneal aberration. This sometimes we encounter that is called nasal septal dislocation. So here the triangular cartilaginous part of septum gets dislocated from the vomeron groove during difficult deliveries. You can see in the picture there is asymmetry in the nares. So the septa has got dislocated. This asymmetry of the nares and you can see here the one side of the nares is flattened and one is normal. So this sign is called Metzenbaum sign. And when you press on the tip of the nose, here in the second picture where you see, normally it wouldn't collapse, but here you see the flattening of the septa and asymmetry of the nares. This sign is called Jeppesen and Winfield sign. So the definitive diagnosis would be by rhinoscopy. Treatment would be by manual reduction by otorhinologist within 3 days. Within 3 days, you need to correct this deformity. Long-term implications would be the septal and cosmetic deformity. And the next birth trauma which we come across is congenital muscular torticollis. There are 3 types of torticollis what we see. One is with the mask, one is without the mask, and the third one is postural torticollis. But the most common torticollis is the sternocleidomastoid tumor. So during delivery, what happens is the malpositioning of the fetus antenatally or during perinatal descent, there could be a ischemia of the muscle, head and neck of the muscle of the sternocleidomastoid muscle, ischemia and edema, which will lead to the muscular atrophy and then later get fibrosed and leading to torticollis. And suppose if there is a hematoma associated with that, it becomes a sternocleidomastoid tumor. So the risk factors are breech presentation and forceps delivery. So when you examine the muscle, you see atrophic muscle fiber surrounded by collagen and fibroblast. Etiology etiopathogens have discussed, and usually it presents at around 1 to 4 weeks. Here what we when we examine the child, we see the head rotated to the opposite side and chin lifted slightly upwards. And then when you try for the passive movement of the head, and we see that if it is less than 10-degree loss of, I mean, if you do a passive movement of the head, and if the limitation is less than 10-degree, that means the torticollis will improve. If you are not able to tilt the head for more than 15-degree limitation, then it indicates for the surgical correction. So the time what we give would be around 6 months. If the correction is not happening beyond 6 months, then it is indication for surgery. We need to take an X-ray also here in this case, because we need to look at the cervical spine for any other injuries, and also the ultrasound of the sternocleidomastoid to look for hematoma or any other pathology in the neck. So next is the nerve injuries. So this is very important, which we come across, though it is not so frequent, but still it is very important. What we see is facial nerve injury, brachial plexus injury, and phrenic nerve injury. So the facial nerve injury, which is seen in almost 0.5 to 1% of all live births. It is mainly due to compression of the peripheral branches of the facial nerve by forceps, or due to compression by the prominent sacral promontory of maternal pelvis. The most commonly affected branch of facial nerve is mandibular branch. What you see on examination is, here you can see that the left side of the baby's face is affected. So there will be a flattening of nasolabial fold and the retraction of the upper eyelid and loss of wrinkles when baby cries. And baby cries, you will see that the normal side of the angle of the mouth will be withdrawn. So these facial nerves are usually, traumatic ones are usually self-limiting, and they recover within 2 to 3 weeks. And another important point when we are examining facial nerve to be kept in mind is asymmetric crying faces. So what is this asymmetric crying faces? This is very common, we come across, where so in this picture, so the second picture, when you see you will feel that it is almost looking like a facial nerve palsy, but actually this is absent depressor angular oris muscle. So which looks like a facial nerve palsy, but when you closely examine the child, you will see that the nasolabial fold is almost intact and baby is able to close the eyes. So how do you differentiate the facial nerve and depressor angular oris absent muscle is by when baby is sleeping or when not crying, you will see here that the face is symmetric. And other methods how you can differentiate is by ultrasound, which will detect the absence of the muscle. And other thing is nerve conduction studies to know the intactness of facial nerve. And while crying, you will see that nasolabial fold on the both the sides will be normal. So the most important topic what I feel for today's discussion is the brachial plexus injury. See, you can see here what is brachial plexus? Brachial plexus is the network of nerves from the spinal cord arising from the spinal cord at the level of C5, 6, 7, 8 and T1. So in this picture, this is the picture which shows the cross section of the spinal cord, and we know that it has got two roots, that is, and anteriorly we have a motor root and posteriorly we have a sensory root, and we have a ganglion arising from the sensory root, and both of them join to form a trunk, and the spinal trunk will give rise to two rami. That's an anterior and this is a posterior rami, and this brachial plexus is formed from the anterior rami of C5, C6, 7, C8 and T1. You can see on the right side, and these rami, the C5 and C6 rami join to form a cord. So these are the roots and it joins to form a cord. And the C7 will not form, it continues just like that, and C8 and T1 will form a other cord. And this cord again divides into anterior and posterior division. So it goes on. So anterior division of C5, C6 and 7 will form anterior, and C7, 8 and T1 form the posterior cords. So from these arises all nerves like musculocutaneous, axillary, radial, median, ulnar nerve, which will innervate shoulder and arm. So injury to these nerves. So injury to these nerves will lead to the brachial plexus injury. A different level will have different kinds of injury, which I'll be discussing now. So the incidence is 1 per 1000 live births. Usually it is right-sided or sometimes bilateral. So what are the risk factors? As I already discussed, macrosomia, multiparous mothers, shoulder dystocia, instrumented deliveries, malpresentation and prolonged labor. So when there is a shoulder dystocia, as you can see in this picture, the second one, middle one, when they are delivering the head, if there is a shoulder dystocia and traction applied during that time can injure the brachial plexus. And the third picture, what you are seeing, sometimes in the arm presentation, when they are pulling the arm, it can rupture the lower trunk fibers. So lower trunk fibers will lead to Klumpke's paralysis. So there are various classification for this brachial plexus injuries. One of them is the Louisiana State University Health Science Center classification, where they have classified it into Erb's palsy, Erb's plus palsy, Klumpke's and Erb-Klumpke palsy. Erb's is involving C5, 6 roots. That's also called upper trunk. Erb's plus will include 5, 6 plus 7. Plus is that the wrist extension will be absent. And in Klumpke's palsy, that is C8 and T1, here the function of the wrist is function of hand is absent. And Klumpke palsy's entire plexus will be affected, and that will lead to flail hand. The most commonly used classification is Naraka's classification, which they use even after operating the brachial. Most commonly used is Naraka's classification. Here they have divided into 4 groups. The group 1 is like similar to the previous classification, the Erb's palsy, where the injury is to the upper trunk. Here they give a prognostic factors also, where this is the most common. Erb's palsy is the most common brachial plexus injury, which accounts to about 50% of cases. Almost 90% of them will recover. The group 2 is extended Erb's palsy, which will involve 5, 6, 7 nerve roots. Here the prognosis is the recovery could be seen in 65% spontaneous recovery. And group 3 is, it involves all roots 5, 6, 7, 8 and T1, where all the muscles of the arm are paralyzed. Arm remains in neutral position with minimal involvement. And group 4 is almost similar to group 3, where it involves all nerve roots. Here the addition is they will have a Horner syndrome, ipsilateral Horner syndrome, that is injury to the sympathetic nerves rising from 8 and C8 and T1, where they manifest with meiosis, anhidrosis and ptosis. So we also need to know the types of nerve injuries because the management also depends upon these types of nerve injuries. So we all have come across this, the Seddon's classification of nerve injury. On the left side, what you see is the cross section of the nerve. Here, these are the nerve filaments. And the nerve filament, the nerve is surrounded by a connective tissue that's called a endoneurium. And the nerve, the group of nerve fascicles will be covered by perineurium, and then the whole nerve is covered by the connective tissue that's called epineurium. So why these are important is the injury depends on the intactness of these connective tissue. So what is neuropraxic injury, which is most commonly we see here in most of the brachial plexus injury. Here the neuropraxic injury, it involves the disruption of the myelin sheath. It won't affect axon. It's only myelin sheath. So the recovery is spontaneous and it recovers very fast. And what is axon-tematic injury? Here the axons are injured, myelin sheath is injured, but the epineurium and perineurium is preserved. And in neurotematic injury, you will see the whole nerve is cut. That is, epineurium is injured, perineurium is injured, endoneurium, everything is injured. So the neuropraxia has got a spontaneous recovery and some of the axon-tematic injuries also can recover spontaneously. Whereas the neurotematic or the avulsion injury will not recover spontaneously and they need surgical treatment. So the most commonly seen brachial plexus injuries, Erb's palsy, which is also known as waiter's tip, where I'm going to show the picture. And when you examine, the baby will have asymmetric Moro's reflex. Biceps reflex will be absent. The main thing what we differentiate Erb's palsy from Klumpke's, the Erb's palsy from the total palsy is the grasp reflex, which will help to differentiate. In Erb's palsy, we have a grasp reflex which is present, whereas in total arm palsy, we don't get this grasp reflex. We need to know that phrenic nerve also arises from C2, 3, 4, 5. So involvement of 5, C5 can be sometimes associated with Erb's palsy. So babies with Erb's palsy presenting with tachypnea, respiratory distress, feeding difficulties, then we need to think of phrenic nerve injury and take X-ray to know the diagnosis. So it is seen that palsy are usually associated with shoulder dystocia, and 1.4 babies of every 1,000 born babies usually have a Erb's palsy. Studies have been done to prevent
Ma'am, unmute yourself, ma'am.
You knew.
Hello, ma'am, unmute, please.
So there are many studies which have been done to prevent this brachial plexus injury. So in one of the studies, they showed that when they conducted a study, 43% of only 43% of medical staff could manage severe shoulder dystocia within 5 minutes. But training to overcome this, for example, use of Mac Roberton position, they could improve the better outcome to 83%. And in UK also, they could find that 70% reduction of brachial plexus injury after training, after training the healthcare workers. So the next is the Klumpke's palsy, which already I mentioned, like how the pull of shoulder or arm presentation can lead to Klumpke's palsy. If this Klumpke's palsy has got poor prognosis, they manifest with the claw hand, where there is a hyperextension of the wrist, and then hyperextension of metacarpophalangeal joint, and then flexion of phalangeal joint. It is frequently associated with the Horner syndrome. So, and also it has got a poor prognosis for spontaneous recovery. And total plexus palsy, which is rare, it's almost involves all the roots. Mechanism is by stretch, rupture, or avulsion injury. On examination, what we find is the flaccid arm, and both motor and sensory nerves are affected. Here, as already mentioned, we need to take an X-ray to rule out the hemidiaphragmatic paralysis resulting from phrenic nerve injury. Prognosis is worst here. And another classification is we need to know the pre-ganglionic injury and post-ganglionic. Pre-ganglionic is just before the sensory ganglion. If there is avulsion of these roots, it's called pre-ganglionic, which the prognosis is really bad and surgery is always indicated. Here you can see the pre-ganglionic injury, where the surgery is the indication. And this is the post-ganglionic injury. Here initially, the most of them what we see is post-ganglionic, and most of them are managed conservatively. And if it is not responding, then only we need to go for a surgical correction. Now, the clinical presentation, as already mentioned, they will have incomplete active range of motion, but preserved passive range of motion. They will have upper extremity weakness, which is asymmetric. When you do Morris, it will be asymmetric, and you see a waiter stiff position in Erb's palsy, and sometimes associated with shoulder subluxation posteriorly. We need to examine for Horner syndrome. Diaphragmatic paralysis always to be kept in mind. If baby having brachial plexus injury and breathing difficulty, then we need to look for phrenic nerve injury. Then winging of scapula, if it is associated, especially when the long thoracic nerve is affected. So in this picture, we can see this is Erb's palsy. Here on the left side, the shoulder is adducted and internally rotated, and at the elbow you see extension. Here, if C5, C6 is involved, these two are involved, shoulder and elbow. If C7 also is involved, then the wrist will get involved, where they will have a wrist flexion. I would like to show a video in this child. This video is I've taken from Dr. Bharat Kadadi. He's a hand surgeon, hand and microvascular surgeon in Manipal Hospital. So you can see here the right hand of the baby. There is asymmetry of movements. The shoulder is adducted, and at elbow it is extended. This is C5, C6 injury, and 7 also, because we can see a wrist flexion. So this is a weighted. Can you see the video? So this is another video. This is a complete total paralysis, total brachial paralysis, where we see a flail hand. He can use his left hand, but the right hand is almost flail. There is no active movements as well as passive. There is no grasp reflex. So this is flail hand, which means there is a total brachial plexus injury. And there is hypotonia. So when they shook a hand, you could see the flail arm. One point we need to keep in mind here is we have to differentiate other conditions like septic arthritis and arthrogryposis, which could be differentials for this brachial plexus injury. So what you are seeing now is a scoring system that is called active movement scale, which has been used to score the movements in this brachial plexus injury. And they score 0 to 7 depending upon the motion. This helps them to assess the child's activity as well as the once they have done a surgery or to follow up the baby to know the improvement, this active movement scale is used. And also known as some test, what they use is cookie test and towel test. Cookie test is they place a cookie on the hand when baby is around 6 months. And they have to bring that cookie to their mouth, and if without flexing the neck, if they are able to bring the cookie to the mouth, that means the biceps are recovering, and there is, they can treat conservatively. And towel test is another where you place a towel on the face of the baby, and then if the baby is can remove the towel on its own without with the affected hand, if he is able to remove the towel, then that means the nerves are recovering. So a role of imaging, we have we need to take a X-ray in any suspected brachial plexus injury to rule out fractures. The most commonly associated are clavicle and humerus fracture, and sometimes they are associated with dislocation, but that cannot be made on radiographs because they are not, the humeral head is not ossified. So in that case, we need to go for ultrasound or a CT and MRI. So MRI is indicated especially when there is nerve root avulsion. And EMG NCV is not so reliable in newborns, but still can be done. So in this, the first two figures, what you see is CT scan, and the white arrow, what you're seeing is the pseudomeningocele that has resulted mainly because of total avulsion of the root. The meninges is bulging out here. In MRI also, you can see the same thing. Now coming to diagnosis, diagnosis is usually clinical. History and physical examination, as already mentioned. So while you are examining the child, you need to look for a bony injury, fracture clavicle, fracture humerus, and asymmetric Morris reflex. And you need to look for the respiratory status of the baby, because to rule out the phrenic nerve injury, and other musculoskeletal and neurological assessment to be done to rule out especially these long thoracic nerve injury and all. The prognosis, 90% of them will recover without any intervention, and spontaneous recovery may take up to 2 years. So some of the prognostic variables, Erb's palsy will recover spontaneously almost 80%, 80 to 90%. Complete recovery possible if biceps and deltoid are anti-gravity. By 3 months, if they are able to use this biceps and deltoid, that means it is favorable. Even when I go through a treatment, also you need to know these points. The poor prognostic factors is like if the baby is not able to use biceps by 3 months, total avulsion, that is avulsion of nerve roots, preganglionic injury, associated Horner syndrome, and Klumpy's palsy is all poor prognostic signs. Now coming to treatment, old school of thoughts, immobilization and all, it is not recommended. So we need to start treatment as soon as possible. Start occupational therapy as soon as you diagnose brachial plexus injury. So passive stretching we need to start at all joints. So immobilization is not at all recommended. So prognosis, as I already mentioned, bicep strength, and if it is recovering by 3 months, then you can manage conservatively. If not, go for surgery. So ideal timing for surgery is controversial, usually recommended between 3 to 6 months. Why we have to do it early is because if there is no innervation, especially in avulsion of these nerve roots, the motor end plates will get fibrosed. So even if you do surgery later than this, it is not going to innervate the muscles. So the treatment involves multidisciplinary team, neonatologist, neurologist, neurosurgeon, orthopedician, and occupational therapist. There are variety. I mean, there are many algorithms which I found for the treatment. It depends on your institution. This was published in JAMA 2018, which is Michigan University of Michigan protocol, where if you are they follow this, the baby is diagnosed with brachial nerve plexus palsy. They advise physiotherapy for 1 month, and then they assess with the AMS scale. And if there is a complete recovery, they continue with the occupational therapy. If there is incomplete recovery, then they refer to orthopedician. Then you do imaging and then electrodiagnostics, and again reassess at 3 months. If the baby, if there is a nerve avulsion, then directly they will take up for surgery. If it is preganglionic or avulsion, they will go for surgery. If not, the occupational therapy will be continued for another 3 months. At around 6 to 9 months, they will assess for biceps. That is the cookie test, what I mentioned, and also the AMS scoring they do. And if it is not improving, then they go for a surgery. If there is a recovery, then they continue the conservative management. This is the algorithm what we follow in our institution. Initially for 3 months we give occupational therapy, and then at 3 months we do MRI, and then rule out for avulsion, preganglionic injury. If avulsion, then surgery. If no avulsion, conservative follow-up. We look for AMS scoring, and as also the biceps recovery. If biceps is not recovering by 6 months, then that's a candidate for nerve surgery. The surgery what they use is either a nerve graft or transfer. So already I've discussed the surgical indication. This is later. Botulinum toxin is used only when there are co-contractures, like gravity and anti-gravity muscles have got contracted and baby is not able to use the limb. In that case, they inject botulinum on one muscle, either a gravity muscle or anti-gravity, and then they release that will help baby to use a botulinum toxin. And next is CIMT. This is constraint induced movement therapy, where they constrain the normal limb, and they encourage to use a affected limb. So because of the brain plasticity in babies, helps in reorganization of these neurons and help to overcome the learned non-use of the affected limb. So next is the phrenic nerve injury, as already discussed. They usually present with recurrent episodes of cyanosis, distress apnea, sometimes feed intolerance. That is because you can see here in this picture, the diaphragm is, the hemidiaphragm on the right side is raised. The dictum is like if you see 2 intercostal space on the right side and 1 intercostal space raised on left side, that means there is a phrenic nerve palsy on the respective side. There are some signs we need to know, that Kinbeck sign and belly dancer sign. Kinbeck is a paradoxical diaphragmatic movement where inspiration and expiration is paradoxical. And then belly dancer is like where the umbilicus moves during inspiration, it moves towards the affected side. The diagnosis is mainly by fluoroscopy, and also you can do a USG study of a diaphragmatic excursion. Treatment is always supportive in mild cases, like if baby is only requiring O2, then you have to treat conservatively. If baby requires CPAP or invasive ventilation, in that severe cases, you can go for the plication of diaphragm. If it is mild case, it will usually recover by 6 to 12 months. They also do a study called diaphragm action potential and phrenic nerve conduction time, depending on which, if they look if the diaphragmatic action potential is absent, or if there are increased latency, it means that is unlikely to recover, and surgical plication is the indication in that case. And also, if baby is invasively ventilated for more than 2 months, in that case, they will go for a diaphragmatic plication. The next is laryngeal nerve pulse, which is rare. That is because of involvement of recurrent laryngeal nerve. Most common is on the left side. They present with stridor, respiratory distress, dysphagia, and aspiration. Traumatic usually recovers spontaneously. If it is bilateral, or if there is a severe respiratory distress, then that might be an indication for tracheostomy. Spinal cord injury, again, it is a rare, where usually associated with high cervical associated with vaginal delivery, low cervical usually because of head trapped in vaginal breech delivery. Depending upon the levels, they manifest, but the prognosis is really bad. Now, coming to fractures, clavicle fracture is the most common fracture. The timing of presentation depends upon it is displaced or non-displaced. If it is displaced, then only baby becomes symptomatic. Here on the right side, you can see a clavicle is fractured. Sometimes they are asymptomatic, and most of the time it is missed. Only we will come to know when there is a callus formation or incidentally on X-ray. So treatment is parental reassurance. And for comfort of the baby, the arm can be placed in a long sleeved garment and pinned to the chest with elbow flexion in 90 degrees. Skull fracture, it can be linear or depressed. Usually the treatment, the treatment would be, the vacuum extractor is used to remove the depression if it is more than 1 centimeter, or if there is associated bleed or neurological deficits. You can see here in this 3D image where there is a depression of the, here in the 3D image we can see the depression of the skull, and this, in this baby you can see the CT showing the depression. Next is the long bone fracture, which is not uncommon. Most commonly seen in humerus and femur. The risk factors are already mentioned, like shoulder dystocia, cesarean, and osteoporosis, prematurity. In this case, when they are delivering a baby, sometimes they do hear a sound of pop or snap, that indicating a fracture. So the prognosis is good for both of them. The treatment would be immobilization with elbow in 90 degrees in humerus fracture, and for femur they splint the leg, or they can give a Paulik harness. Now the last one is the intra-abdominal injuries, which is rare. This is maybe sometimes resulting from maternal abdominal injury, or sometimes when they are pulling the baby during breech extraction. What we encounter is subcapsular hematoma of liver, splenic rupture, adrenal hemorrhage, and renal injury. Patients, it can be mild to severe form. In severe forms, they can present with shock, hematoma, and in that the treatment would be correction of shock, hypovolemia, and coagulation has to be correct. and ultrasound to rule out any associated injuries in the abdomen, and also the X-ray and CT has to be done if required. X-ray has to be done to know the bone injuries. To conclude, I've almost covered most of the birth traumas. Birth trauma occurrence is unpredictable and unavoidable. Hence, we need to be prepared for that. Recognition of trauma is very important, and also we need to have a knowledge about the course, treatment, and prognosis. It's not only the perinatal event, also injury can result from resuscitation. So we need to take care about it. Careful physical and neurological examination need to be done and establish whether additional injuries exist. It's not only one injury. If you find one injury, you need to look for the other injuries also, and look for asymmetry of structure and function. Specific examinations such as cranial nerve, joint range of motion, scalp, and skull examination is also important. Thank you.
Dr. Prashant?
Hello.
Ha.
Thank you, Dr. Shridevi.
Yes.
Thank you.
Yeah, wonderful presentation. So now we'll move on to the next session. And Dr. Raghavendra,
Prashant, let Raghavendra talk.
Yeah, I am here.
Yeah,
Yeah.
please go.
Yeah. Welcome, Dr. Suhail. Suhail is our active joint secretary. Presently, he is practicing in Hubli, and he is going to present on common neonatal problems in OPD practice. So carry on, Suhail.
Thank you, Raghavendra. Are the slides visible?
Yeah.
Slides
Start
are visible?
sharing. Share the slide. You have not shared the slide yet. Yeah.
Is it? It has come?
Yes. Put it in slideshow.
Yeah. Okay. First of all, I'd like to thank NNF Karnataka for giving this opportunity, and very special mention for Kotresh sir, Dr. Prashant Gowda, and Dr. Dinakar sir for arranging these webinars on a daily basis, almost on a daily basis, 4 days in a week. It takes away a lot of time, and a lot of gratitude, and hats off to you, sirs. My topic is common neonatal problems in OPD practice. Okay, so this is basically oriented at PGs, as all the seniors will definitely be knowing a lot about it. So that neonatal OPD practice is one of the places which is not mentioned much in the PG courses. So we'll start with the introduction. Neonatal period, as we all know, is from birth up to 28 days of life. In that specifically, we classify it into early neonatal period and late neonatal period. So early neonatal period will be the first 7 days of life, and up to 8 day to 28 day will be the late neonatal period. We need to know this basics because neonatal patients form more than 20% of the OPD practice of any pediatrician or neonatologist. So presentation is quite different from older children, and the clinical features overlap a lot. So we also need to know the gestational age and birth weight of the child, because this also influence the diagnosis and treatment which you're going to prescribe. So before going to the problems, we'll see what a well baby is. So a well baby should feed well. It should sleep well in between feeds. It should have good urine output. By good urine output, we mean at least 6 to 8 times in 24 hours. The baby should be pink, well perfused, and breathing comfortably, active and responsive. And when it comes to use, you see it should be gaining weight appropriately. So why to detect these problems? The first most concerning part is the parental concern. Most of the families nowadays being nuclear families, the educated family who have shifted to the metropolitan cities, they are more concerned, and they usually don't have elderly grandparents to guide them. One thing. Other thing is neonates, they deteriorate very fast, so early detection is a must so that we can give prompt treatment and reduce morbidity and mortality as far as possible. Okay. This slide is for the PGs. These are the various complaints with which they can come for. They can come with bruise discoloration, where we have to differentiate between if it is central cyanosis or peripheral cyanosis. And in case of central cyanosis, the baby may be coming up with duct-dependent lesion or cyanotic CHD. Pallor, whenever the baby might have had cephalhematoma, we have just Dr. Shridevi told about the birth traumas. So baby might have undergone some trauma and the bleed inside. So baby may present with pallor, anemia. Okay. Convulsions, again, right from day one, babies are at the risk of having convulsions with various spectrum of presentation, from subtle seizures to focal seizures. So knowing about convulsions also is very important. Poor feeding, apnea, jaundice is again another important thing, where we want to know if it is unconjugated hyperbilirubinemia or conjugated hyperbilirubinemia. Abdominal distension is again one of the most common complaints which come up, especially when the mother is feeding well and the grandparents are worried about the abdomen. Okay, ear problems. Whenever the baby is crying, they have to relate it to something. So it goes either to the stomach. For most commonly, it will go to the abdominal pain and then comes to the ear pains. And then we have neurological and surgical problems, which we'll be dealing a little later. Just look at this slide. This slide I've given a pictorial presentation where you can see a bloated baby, then you can see a baby with vomitus. We have put this slide so that you can have a pictorial presentation in your brain, because what I speak now may vanish in another some time, but this pictorial presentation will stay you for a longer time. First we have the bloated baby, then vomiting baby, baby with a rash, irritation, seizures. You can see the posture of the seizure photo. Then baby passing stools, poor appetite baby, bulging fontanelles, breathing problem baby, constipated baby. So these are all the presentations which we'll have in our OPD. Okay, so now you'll keep seeing many colors coming into my slides, because being a pediatrician and neonatologist, we need to keep our OPDs colorful. Just bear with me. So as I said, presentation of cyanosis will have to rule out central cyanosis. Peripheral cyanosis could be because of the cold, where as the baby has come out of home, a little cold stress. Peripheral cyanosis can be overlooked if we see that the saturation is in the normal range. Central cyanosis usually has some underlying pathology and should be investigated. We have to see for respiratory insufficiency. Has the baby got pneumonic patch, or as the baby is really having respiratory distress? Is there any indrawings? Or the central cyanosis can be because of CNS depression, and as I mentioned a little while earlier, a duct dependent lesion, or the baby might have PPHN. So to rule out between respiratory and CNS cause, we'll have to do the hyperaxia test. So this baby will definitely need admission to the NICU. So pallor, we see anemia could be because of acute hemorrhage. Again, maybe because of birth trauma, or could be HGN, could be because of hypoxia, hypoglycemia, and some babies may present with shock and sepsis. Okay. So convulsions here, you see the mother holding the baby. Whenever you are in the OPD and you see that a baby is having convulsion, you have to attend to it. But still, you need to guide your receptionist to guide the parents to how to hold the baby when the baby has a convulsion. Here you will see that the head is lower than the body and the baby is in the lateral position. This position is important so that baby does not aspirate and cause further problems. Okay, so as we are aware, for the first day we have different causes. First will be hypoglycemia, hypocalcemia, and then we'll have drug withdrawal can be a possibility, and then sepsis comes into picture. As the days progress, sepsis slowly starts taking predominance and the other causes start going back. In India, we are lucky, we don't have much of drug withdrawal convulsions, so we can, but still in metro cities, we need to consider that also. So here you can see the urine output we are showing. Baby has not passed urine for the last 24 hours and they may just come running to you. So we need to be aware that baby might have passed urine just before the delivery. So once the baby is out, we need to wait at least for 48 hours before we start acting on the urine output. Okay, and the stools baby has to pass within the first 24 hours. If not, we have to have a clear examination of the perineal region, the anus, and see for any anorectal malformations. Temperature. This problem usually starts right from day 2 of life, where the grandmother comes in, specially seen with mothers undergoing cesarean section, and there's some amount of problem with feeding. So babies turn up with high degrees of temperature. So we need to know that we have to rule out if the baby is sometimes just because of the wrapping and all and the environment, baby may be warm. But if the body temperature is above 37.5 degrees Celsius, that is the time we need to consider dehydration, which might be the first common cause. And then we have to be aware of it because it may lead to hypernatremic state. And then we think of sepsis. Okay, environment, especially in North Karnataka with the high temperatures here, we have to be very careful with the baby's temperature. Baby may turn off with fever because of the high wrapping and overclothing of the baby. Hypothermia is more common, but everybody, even the adults at home and the mother will come telling you that the baby is having hypothermia and you can act immediately on it. Then comes my baby is not feeding well. This is again one of the most common complaints the mothers come from. It could be because maybe because the mother is a preemie and the milk has not started fast. The first 2 days anyway, colostrum will be thick and scanty amount. Then there may be nipple issues with the baby, as you can see in the pictures. It could be a flat nipple, it could be an inverted nipple, or it could be a retracted nipple. So here our examination of the mother comes into picture. It is always advisable that we have some breastfeeding consultant available for. Then in the term babies who was feeding very well earlier, suddenly now the baby is not feeding well, illness has to be ruled out. Sepsis is the cause, hypoglycemia, or if there was perinatal asphyxia, if there is any cerebral defects, metabolic disorders, or sometimes even connectors. Now, my baby is, puking every now and then. See, we need to know that if the baby is puking out just small amount of curdy milk 2 to 3 times in a day, then we can count it as normal. When is it abnormal? When it is repeatedly there with almost every feed, or the amount of vomitus is quite high, the baby is going in for dehydration, the baby's urine output is decreasing. That is the time when we need to evaluate the baby, and it could be because of pyloric stenosis, it could be because of overfeeding, it could be because of milk allergy as well, and sepsis as the last option. The next complaint which the mother will come with is the nasal stuffiness or noisy breathing. As you see here in the picture, you see a little redness of the nose. That will be because the mother would have tried to clean out the nostrils with cotton buds or something. We need to know that this is not complete blockage. It is just at a relatively narrow passages. The baby has this, and when you inquire about it, and they will come specifically saying, "Ratri gurgur jasti antaitre." The baby is making more noise in the nights. It has nothing to do with the day or the night. The nostrils are of this smaller size because the outer environment is calm, silent. They hear the noise more during nights. So we just need to reassure the parents, and you just need to tell them that if the baby is feeding well and the baby is active, looking around and feeding well, then you need not worry about this noisy breathing. Sometimes phlegm, usually very rare with kids, but we have to exclude upper as well as lower respiratory tract infections. These babies will have pooling of saliva and secretions in the oropharynx. Very rarely newborns may also come with cough. It is usually associated with choking during feedings, but we need to rule out bronchiolitis. If the baby is otherwise well, we need to reassure the parents medication is not necessary. Okay, if you feel that it is a reflux, then probably you may add on domperidone. But usually medication is not required. We just need to teach them the burping technique, and with that things will be fine. Please avoid sedating cough syrups, especially in the first 6 months, and very especially if the baby is a preterm. Crying baby. This is probably the most common complaint. Baby is crying, and more so in the nights. It is normal for the baby to be tense and angry, red face looking while crying. And whenever the baby is crying, and even if we try, sleeping in a supine position and taking our legs and arms up, our abdomen also gets tensed. But what happens is the grandmothers are very apprehensive. They'll see that the baby's abdomen is getting tense, and they'll bring to you. We need to know the common causes of crying. Usually hunger would be 90% of the time. The remaining times would be soiled diaper. Either the baby is too hot or too cold, it is overstimulated, and sometimes it is also a reaction to the mother's mood. Or we need to rule out if the baby is really unwell. Irritability, as you can see in the picture, whenever a baby is irritable, we better figure it out, or else baby will give us something to worry about later. So there are intra-abdominal conditions, could be because of the meningeal irritation, drug withdrawals, congenital glaucoma, and sepsis. This thing needs to be kept in mind. Okay. The next complaint is colic. Colic usually begins from the second week of life, 2 to 4 weeks of life, and ends by 3 to 4 months of life. The cause is very uncertain, and many say that it is because of the excessive air gulped while feeding. We need to reassure the parents that the baby is fine. There is no much of abdominal distension. The abdomen is soft. Baby is crying well in between feeds. Need not worry. But again, as I said earlier, we need to rule out the medical cause, find out if there is any allergic food in the mother's diet, or the baby is being fed top milk or cow's milk. Okay. And you can just show them that hold the baby prone across the lap and rub the back, soothe the baby, and the baby will be calm. So during this time, we just need to explain them about improving the feeding technique, burping, avoid underfeeding or overfeeding. Overfeeding also can cause this crying behavior, colic. Okay. Colic drops, very rarely Semethicone drops are used. It helps in breaking the gas particle inside the tummy, but usually with mild massage, it goes off. The next thing is bowel movements, especially the primates come up with the baby is passing green stools. So it is the meconium. Usually the baby has to start passing it in the first 24 hours of life. It is a thick, dark green or black odorless stools. Usually contains mucus, epithelial debris, and bile. So once there is milk let down, then when the colostrum is changing to the regular milk, the baby's stools also start changing in consistency. As the baby, as the days pass, baby day 3, day 4, stools gradually start changing color. From green color, they go into golden yellow color and then go to yellow color. And these are called the transitional stools. Transitional stools, whenever the baby comes to your OPD on day 3, day 4 of life, they would have usually already shown to somebody nearby their house, and they'll come up with 2 days of antibiotics. Remember, this is just transitional stools. You don't have to advise any antibiotic. This will pass on as the days go by. We need to tell them that during this period, we need to reassure the parents saying, if the baby is breastfed, the motions color is bright yellow, loose, as you can see in the picture on the top, this thing, bright yellow, loose, seed-like particles is with breastfed. If the baby is formula fed, the color is a little tanned or yellow. It is firmer than the breast stools. So during these times, we need to tell them passing 2 to 6 times per day is fine. We need to see the baby is sucking well, breastfeeding well. There's adequate urine output at 6 to 8 times per day. The baby is gaining weight. So you need not worry about this diarrhea.
Yes, sir. Unmute yourself. Yeah, unmute, sir. Yeah.
Okay. So the slides are there?
Yeah, slides are there, sir. But it was.
Okay,
Yeah.
okay. So as I said, the change in bowel habits will be there with time. Slowly as the days go by, the stools will become a little more solid. So and the gastrocolic reflex will also diminish with time. So you'll not have motions every time the baby passes stools. So infrequent stools and infrequent.
Slides full mode. Full screen.
Okay, screen have not slideshow.
No, it's coming.
Oh.
Slideshow. Yeah.
Okay, fine. Okay. So if the stools, if they are infrequent stools and the baby is passing a little solid stools, that is fine. If it is firmer just as a peanut or butter, it is fine. Otherwise, the baby is gaining weight, you're passing very nicely, feeding properly. There's no abdominal distension. Please do not count as that constipation. It is a normal variant for the newborns. And it is common for newborns also to grunt, groan, and strain during passing stools. So it should not be counted as stools. Constipation. Constipation will be hard, dry, and especially after passing motions. If you examine the perianal region, there will be erythema and redness around the anus. So this is the time when we need to consider hypothyroidism and Hirschsprung disease. Okay, coming to neonatal jaundice, as you see in the picture, yellow in baby isn't cute. Okay, so what are the common causes of jaundice? We see physiological jaundice, which starts usually from day 2 to day 3, then breast milk jaundice, breastfeeding jaundice, and pathological hemolytic jaundice. We have ABO or RH incompatibility and G6PD deficiency. In this slide, you can see the Kramer's staging, stage 1, stage 2, then 3, 4, and 5. So this chart, I believe everyone should have in their OPDs, so that whenever the baby passes that stage 2, and you are more careful when it comes into stage 3, level 3, the bilirubin level will vary somewhere between 8 to 16. And this is the time we need to investigate the baby and see for the levels of bilirubin. So physiological jaundice in a term baby starts in day 2 to day 3. It will peak around day 4, day 5, and start falling after day 7. Preterms, it peaks around 5 to 7 days and start falling after 8 to 10 days. Okay, so when we call it as prolonged jaundice. Prolonged jaundice is in term babies if the jaundice persists more than 14 days, and in preterm babies if the jaundice persists for more than 21 days. The common causes for prolonged jaundice is breast milk jaundice, hypothyroidism, urinary tract infection, biliary atresia, and neonatal hepatitis. So you can see the king lion here, and the baby again in king lion's hand yellow. So yellow doesn't look good on babies. Coming here to breastfeeding jaundice. Breastfeeding jaundice, usually you can call breast non-feeding jaundice because it is more of a starvation jaundice. The onset is early, and the exaggeration of early jaundice with higher serum bilirubins because of the dehydration. It will be due to the inadequate breastfeeding and insufficient caloric intake. So it enhances the bilirubin absorption. Breast milk jaundice is usually late onset and prolongation of the physiological jaundice. The serum bilirubin usually keeps rising even from day 5, and it is due to the pregnenolone present in the breast milk. Levels stay elevated for them and start returning to normal by 4 to 12 weeks of life. The treatment here would be stopping breast milk for 48 hours and then restarting it, and the bilirubin levels fall in this 48 hours and then never go back to that previous level. But we need to be very careful because we don't do this on OPD basis. There's high likelihood that mother shifts from exclusive breastfeeding from that period. So see to it that you admit the child for breast milk jaundice and then keep the baby away from breastfeeding for 48 hours and then restart. Send the baby again on exclusively breastfed. So now we'll come from head to toe. In the scalp, as Dr. Shridevi already told, cephalhematoma is most common finding. They'll be worried because of the shape of the head. We need to explain to them that it is just because of the normal delivery or the ventos and prolonged stage 2 of delivery. And they are worried about the shape of the heart. What we need to see it is a subperiosteal swelling, so it will not cross the midline. Okay, and it will have its boundaries limited to the bony margin. Reassurance, majority of the times reassurance helps. The only thing we need to look is because if the cephalometoma is quite big, the baby may land up in anemia, and day 4, day 5, because of hemolysis, there will be exaggeration of the physiological jaundice, and very rarely we may say calcification. Okay, coming to eyes, eye sepsis is again common. Babies will have greenish discharge, as you can see in the left side of the baby is having sticky green discharge. We take the gram stain eye swab and send it for culture. You can start the baby on chloramphenicol, 1 drop 6 hourly, or tobramycin should be suffice. Squints, usually in the first 3 to 4 months, intermittent strabismus is normal. We wait for the first 3-4 months. If any misalignment is there after 4 months of age, baby needs to be evaluated. Remember, even in the first 3 months, if the baby is having divergent squint, it is always abnormal. There is again a possibility of a flat nasal bridge, and the baby may look as a having squint. So this is called pseudo squint. So as I said, if at 4 months, if the baby is still having squint, we go for the Herzberg corneal reflex, where we put a torch in front of the baby's eyes from around 1 feet distance and see for the corneal reflex. If it is symmetrical, it is normal. If it is going nasally, then it is exotropia. Otherwise, it is esotropia. The next common is watering from the eyes. Usually we see tearing and sticky eyes. If the discharge is clear, it usually is the blocked nasolacrimal duct, and we don't need any medicine for this. Just nasolacrimal duct massage will help. In massage, we don't have to try any special movements. It is just the pressing movement at the inner canthus of the eye and then at the nasal ala of the same side. So both side pressing is important. We need to see that both side the blocks goes off. Once the block is taken care of, in case this persists despite this for a month or so, we need to take a opthal opinion. In the ear, we can have preauricular sinus. It is usually the remnant of the first branchial cleft. It starts from the anterior end of the upper helix of pinna and runs downwards and forwards towards the cheek. Its usual length is around 5 to 10 millimeters. Okay, it is associated with renal hypoplasia, hearing impairment. Usually we call it branchiotorenal syndrome. Surgery is indicated only if the sinus is discharging. We suspect infection or abscess. That is the time we take the baby for surgery. The next most common ear problem is the preauricular skin tag. It is usually associated with other anomalies like cleft lip, cleft palate, golden hair syndrome, Treacher-Collins syndrome. It can be isolated as well. It usually doesn't cause much problem, but majority of the babies, they are operated just for the cosmetic reason, and we remove the skin tag. Just some time back, we heard about torticollis. Torticollis, it is not obvious at birth. It usually is diagnosed at 1 to 2 months of age when the baby's face starts turning away from the affected side. So, and the baby presents with a sternocleidomastoid tumor most commonly at the age of 3 to 4 weeks. Why you are worried is it may cause facial asymmetry, plagiocephaly, and sometimes even amblyopia if it is left untreated. And it can be other way around, that the torticollis could be because of the visual impairment as the underlying cause. So we need to know what the cause is. And if it is because of the sternocleidomastoid tumor, physiotherapy for stretching exercises helps usually. And if at all there is no improvement at the end of 1 year, we go for tendon release. Here, as you can see in the picture, there is cystic swelling in the floor of the mouth under the tongue. It is called ranula. It is a mucus cyst related to the sublingual salivary gland. It usually disappears spontaneously. Very rarely, if the mechanical obstruction is it causing for breathing, that is the time, or it is not allowing the baby to feed, that is the time when surgery may be needed, but usually it resolves by itself. Here you can see the tongue and the buccal mucosa backside coated white. It is a white curdy plaques present in the orobuccal mucosa. It may extend to the pharynx if not treated early. Usually the presentation will be that the baby is not feeding well. Okay, and if you try to scrape it off, you may end up having mild bleeding. So the treatment would be either clotrimazole 1% mouth paint 4 times in a day for 5 days, or else syrup nystatin 1 lakh units QDS, or miconazole oral gel. Here you can see there are two pictures in the natal teeth. The first above one is the predeciduous teeth which was erupted at birth. It is usually the lower incisors. It will be loose and it has to be removed so that we avoid it aspirating into the trachea. The lower picture which you see, here you see that there are two incisors, lower incisors, which are firm. They are not loose like the above picture. And these are the true deciduous teeth you see in 1 in 2000 births, and these should not be extracted. These usually we see in Ellis-Van Creveld syndrome or Pierre-Robin syndrome and Sotos syndrome. Facial nerve palsy, we had read about it, usually because of birth trauma. It is the lower motor neuron lesion with varying severity. There will be difficulty in sucking, drooling of feeds on the affected side. And if it is facial nerve palsy, it usually resolves spontaneously within weeks. The other differential diagnosis for this is absence of depressed angular oris. Okay, but in the absence of angular oris, we'll have nasolabial fold will be maintained, and will forehead creases will be nicely maintained. Here you see in the picture on the left side, the forehead creases are not there. Right side nasolabial fold is maintained, but baby is not able to close the eyes. It is the same baby. Coming to the chest, both girls and boys can have enlarged breasts with milk secretion. Previously also we used to call it witch milk. We need to reassure the parents that nothing is going to happen. It resolves on itself. But if you tell like this, you will see another 2-3 days the grandmothers will bring back the baby in this way. They will try to take out the milk and end up with cellulitis of the area. So it is always advisable that you ask them for hot fermentation, and they'll be happy with that, and it resolves with time. Coming to the umbilicus, we'll discuss umbilical sepsis, granuloma, polyp, and hernia. Umbilical cord usually separates within the first 1 week of birth, but the mean time is 7 to 14 days. And if it persists for more than 14 days, it is delayed separation. Could be because of the faulty neutrophil function or chemotactic defects, or there may be a bacterial infection. Here you see in the picture there is periumbilical erythema and induration, and there may be purulent discharge along with it. What we need to see is if the diameter is more than 1 centimeter and the baby is feeding well or not. If the diameter is more than 1 centimeter, you have to immediately admit the baby as umbilical sepsis and start on with parenteral antibiotic therapy. If it is less than 1 centimeter, the baby is feeding well, you can reassure the parents, and you can give topical antibiotic and send them home. Umbilical granuloma. Most common presentation of umbilical problems. The granulation tissue will be at the base, soft, granular, dull pink or red. Seropulent secretions are seen. We have to differentiate it from gastrico-intestinal mucosa. Okay, so what will be the treatment? Usual, most common, easiest treatment would be common salt crystals, which we call Kaluppa or Dapuppa. South Karnataka we call it Kaluppa. In North Karnataka we call it Dapuppa. Applies as we clean it with cotton, the same way you just dip it in water and clean it with the common salt crystal. So that will help in getting rid of the granuloma. Usually we ask them to do it 3 to 4 times in a day, or around 3 to 4 days. Cauterization with silver nitrate is an option, but usually common salt suffices. Umbilical polyp, very rare. It is the remnant of the Vitelline duct or uricus. It is firm and bright in color. Mucoid secretions will be there. Sometimes fecal material or urine may come out. Surgical excision of the entire tract or the urethral remnant is necessary. Next, umbilical hernia. Umbilical hernia is because of the imperfect closure of the umbilical ring. As you can see in the picture, it comes out like a stump. It is soft. The skin is normal colored. The swelling protrudes, especially during crying, coughing, or straining. but it can be reduced easily. We need to see it, reassure the parents that it usually disappears by 1 to 2 years of age. Majority disappear by 6 months, and 80% disappear by around 3 to 4 years. Rarely we need surgery for this case. In case it persists for more than 3 to 4 years, the parents are very anxious about it, or if it gets strangulated. These are spinal dysraphisms which we see in the pictures. It is most common in the lumbosacral region. It can vary from skin dimple to a sinus tract, hairy patch to hemangioma or lipoma. So if it is a sinus tract, and in the neonatal period we don't do anything, but as the baby grows and is stable for an MRI, we get an MRI spine to see for any defect there. Usually the most common defect in the MRI would be the tethering of the cord, which can be corrected surgically. Coming further down with the hormonal withdrawals, we can have vaginal discharge. It could be thick mucus white colored, or sometimes it could be blood as well. Blood, previously it was mentioned as pseudomenses, and they are really worried. The mothers first, especially primaries, they'll be really worried with this. We need to assure them that it is because of the withdrawal of the maternal hormones that this has happened, and it goes off in 2 to 3 days. Further, when you come down, remember we are in India, especially if you have an asphyxiated baby. If you have an asphyxiated baby and you tell the parents that your baby has got asphyxia, the baby may not be completely normal by brain, they may accept it. The moment you say कि बच्चे को नीचे कुछ problem है, then they're all worried about it. Okay, so we need to be very careful. We need to be sure of the diagnosis whenever we are commenting about the groin problems, especially hydrocele is one of the most common things. We need to be sure. Hydrocele, we have to do a transformation test and palpate above the swelling. Okay, hydrocele usually resolve in by 1 year of first birthday. If it does not resolve by itself, then we have to plan for surgery. Then the inguinal hernia. Inguinal hernia is the scrotal or groin mass which fluctuates with size. Obviously, during it is more during crying and straining. It is good if it is reducible, but we have to know that the chances of strangulation is very high. So inguinal hernia, as soon as the baby is fit for surgery, we go for bilateral herniorrhaphy. And as I said, you have to be doubly sure before telling the parents that there is undescended testis. Okay, and once you say undescended testis, the full family is going to pounce on you with multiple questions. You need to be clear that where is the position of the baby, get an ultrasound done, and allow the testis to come down for around 3 to 6 months. In the Western countries now, they mentioned that up to 6 months we should operate the baby orchidectomy at 6 months, but few places in Indian scenario we are still persisting with around 9 months to 1 year. Phimosis, it is physiological in infancy. Up to 90% under 3 years have phimosis. So it slowly resolves with time. So at 3 years or 4 years, if the baby is still having phimosis, then we try for treatment, or else it resolves by itself. Hypospadiasis. Hypospadiasis, if it is a urethral opening on the ventral aspect of penis, if it is usually associated with cordia as well. If it is glandular and if it is distal part, usually it does not cause much of a problem with urination. But if it is proximal, with cordy, we need to rule out disorders of sexual differentiation. If the testes are present, we are lucky. We may find it easier to explain to them. But if the testes are undescended, along with hypospadiasis, disorders of sexual differentiation has to be worked up. And we have to remember that whenever we see a case of hypospadiasis, and especially if it is a Muslim child, we need to tell them that circumcision should not be done till we correct the hypospadiasis. Hypospadiasis, because in the correction we need that skin for correction. Coming further down, congenital talipes equinovarus, where the foot of the child will be internally rotated. It could be either because of postural problem or passive structural problem. If it is postural because of position in utero, passive stretching will help. You can just ask the mother to do it every time she's feeding the baby. If there is structural problem, then it doesn't get corrected with passive stretching. So this is the time when we need to take a surgical or orthopedician opinion for serial casting and if need be surgery. Pseudoparalysis, as we have already heard in the earlier talk, it could be because of the clavicular fracture, dislocation of the shoulder, nerve injuries, or osteomyelitis. I will not go into much into it. The skin problems. Skin problems we have divided into five. One thing. Well, first thing I'll speak about rash. Then we'll go to the staphylococcal infections. Then the dermatitis part, and then with salmon patch, port wine stain, and then I'll come to the Mongolian spots and Kapha alert spots. So diaper rash, it is usually because of irritant dermatitis, because of the also called ammoniacal dermatitis. You will see that typically because the urine has not gone inside, the creases, skin creases will be spread, as you can see in the diagram. So what is the treatment? Frequent diaper changes. You specifically tell the mother that diaper, as far as avoided when the rash is present, it has to be avoided. Whenever the rash is not present, still you need to put in a word to the mother saying that if you see while changing a diaper that urine has collected or stool is still liquid and moist, we need to change diapers a little more earlier. Okay, sometimes allowing the area, exposing it to air for drying also helps in healing. Zinc oxide creams fasten healing. Sometimes we even use it prophylactically. So Candida albicans rash, as I just mentioned earlier, because it is because of the moist, warm areas, it will involve even the folds of the skin. More common is neck folds, axilla, and the diaper area. Confluent, it will be confluent erythematous plaques with sharply demarcated edges. These are the 4 things. Okay, they can present with satellite lesions, the pustules on the contiguous areas of the skin, and the treatment will be muconazole cream or clotrimazole cream. Coming to the staphylococcal aureus infections, it can present as pustulosis, bullous impetigo, or scarlet skin syndrome. So pustulosis is usually seen on 3rd to 5th day of life. Discrete pustules with erythematous rashes. Please look at the pictures. You can see discrete pustules, and this is usually seen in the diaper area region, periumbilical and neck region, and the lateral aspect of the chest. So systemic cloxacillin is advised. Here you see bullous impetigo. They are flaccid blisters. They rupture quickly and become superficial erosions. They may be round or oval in shape. Even here, the treatment is systemic cloxacillin or cephalosporin. Seborrheic dermatitis are usually seen on the face, eyebrows, and scalp. On the scalp, it is also called as a cradle cap. Okay, onset is within the first 2 months of life. With seborrheic dermatitis, we need to know that it is a yeast infection caused by Pterosporum ovale. It is greasy yellow scales on erythematous base, and there will be very little pruritus, but thick scales. And it can be localized or generalized. And sometimes if it is severe, even there will be fissures in the scales and it can get infected secondarily. If not infected, it usually improves by itself by the end of 1 year. The treatment given is we get the cradle cap shampoo. We apply olive oil on the scalp to soften the crust, usually done 1 hour before giving birth to the baby. Very rare cases, we use 1% hydrocortisone cream very sparingly. This is the very nearer differential diagnosis to seborrheic dermatitis is atopic dermatitis. We need to distinguish it, and it is very difficult during the neonatal period. But we need to see that with atopic dermatitis, the lesions will be very pruritic. the baby will try to scratch itself and rub against the nearby objects, whatever is available. And atopic dermatitis, usually we see diaper area being spared. Okay, and once the area is gone off, it's not that atopic dermatitis, that area is gone. Again, there can be recurrence in that area. It will be dry, white, scaly lesions, and usually will good, strong family history will be present of atopy. Okay, emollients work nicely. Liberal use has to be done immediately after bath, and 0.5% to 1% of hydrocortisone cream. But we need to see that the baby doesn't get superimposed infections. This is erythema toxicum. We see usually in 50 to 75% of the term babies, but very rare in preterms. Okay, the basic lesion is 1 to 3 mm of papules evolving into a pustule with a halo of erythema. Even these can be few to numerous inside. Red skin with yellow-white centered lesions. They usually start with the trunk and going to the extremities and face. We'll see that palms and soles are always paired almost. Okay, usually noticeable after 48 hours of life, and may appear as late as 7 to 10 days. And in the smear, you will see a lot of eosinophils. It is a benign condition and it resolves spontaneously. This is neonatal melia. Again, the problem is mothers will be worried about the look. You need not, you can assure them that this is very common and it goes off with age. Now I'll speak about patches. Salmon patch, you need not worry. You can remember patch can always be removed. So salmon patch goes off whenever you come across, and whenever it is present on the glabella, it is called angel's kiss. Okay, and on the nape of the neck, we call it stork bite lesion, and stork bite lesions usually persist. And these are flat pink macular lesions at birth, and present on forehead, upper eyelid and nasolabial areas, and they usually resolve by 1 year of age. Port wine stains, remember, stains usually don't go easily. Port wine stain is here to stay. Whenever if the baby has port wine stain, we need to see that how much area is involved. Most commonly the face is involved, and sometimes the trunk and back limbs are also involved. Usually unilateral, and it will be very pink and macular at birth, and with time it darkens to reddish purple. Okay, it is a vascular malformation of the dilated capillaries. It will not involute by itself. If it is causing more of a cosmetic problem, we will have to give pulse laser therapy. And next is strawberry hemangioma. It is a bright red, raised, well circumscribed lesion, and the moment you look at it, you will make it out that it is a vascular lesion. It may not be present at birth, and even if present, it may be pale, but it starts increasing in severity as the first year of life goes, and slowly it starts involuting, and by the age of 4 to 5 years, majority of them involute. So whenever we come across a case of strawberry hemangioma, we need to know that complications are ulcerations. It may bleed anytime. It may be associated with visceral involvement, like hemangiomas may be present in the liver, the GI tract, lungs, CNS. It may even be present in the trachea, causing severe stridor. So that is time we need to get an MRI and rule it out. And if the hemangioma is causing problems, that is the time after ruling out cardiac problem, we start the baby on propranolol if required. If not, we just reassure the parents that it will subside at, by 4 to 5 years. This is nevus tabacum, single yellowish slightly raised hairless plaque on the face or scalp. It is usually because of the excessive sebaceous glands and malformed hair follicles. Why this is important is usually after puberty we see it turning into a tumor, maybe a benign or malignant, but most commonly it is seen that it turns into basal cell carcinoma. So more before puberty we need to excise this lesion, and usually before the child goes to school will be the right time. These are the cafe alert spots, most commonly seen with neurofibromatosis, and many other lesions like McCune-Bright syndrome. These are light brown, round or oval macules. They will have smooth edges varying in size, and these also do not resolve with time. Okay. On histology, there is because of the melanin in the basal keratinocytes without melanocyte. Okay. These are the, again, for the academic purpose, the various syndromes where we see alert spots. Neurofibromatosis being the most common, McCune-Albright syndrome, Russell-Silver syndrome, Fanconi's anemia, tuberous sclerosis, Gaucher's syndrome, Shirek-Hagashi syndrome. Then Mongolian spots, we see almost in 90% of the blacks, 80% of Asians, and 10% in whites. It is brown, gray, or blue macules, and most commonly seen in the lumbosacral area, occasionally present in the upper back and limbs and face also. They may vary in size and number. So here also there is infiltration of the melanocytes deep into the dermis. They usually fade away by 1 year, first year or 2 years of life. It is not that the spots fade away, but the skin gets a little more translucent, that the transparency of the skin goes down. So we feel that the Mongolian spots have faded away. Okay, here on the lips you can see blisters. These are healed like calluses. They resolve by itself. You can see here on the hand, there are clear blisters. It may present wherever the baby sucks because of the sucking, repeated friction of the skin. There is clear blisters, and it may be sometimes it may be so severe that it needs debridement and treatment. Okay. So here we have come. I come to close because the list is endless. I'll stop my OPD first visit cases. Here, whenever we attend a delivery or we have discharged a baby from NICU or from after a normal postnatal period, the baby comes for follow-up. So what all things we need to see? We have to start with growth monitoring. We have to chart the growth. We see for neurosonogram in a preterm baby if it to see for IVH or other abnormalities if the baby is developing hydrocephalus for any reason. And then hearing assessment, it has to be done for every baby. Now we have seen that more than 50% of the hearing impaired babies have not visited NICU. Previously, it was that only babies with who are going into NICU were done hearing assessment. OAE was done, but now it is advised that we get a hearing assessment for every baby born, so that we bring down the hearing impairment by drastically. ROP scanning is required for preterm babies. I'll not go into details. So in the next slide, here I would like to tell you about the common surgical problems or medical problems which are not expected. Like we need to be really fast about it. First, medical problems, we need to rule out cardiac problems like duct dependent lesions, and then right to left shunts in the congenital heart disorders. And then if the baby is vomiting blood, we have to rule out late onset HDN. Surgical problems, especially if the baby's abdomen is distended, baby is not sucking well, and baby is lethargic, we need to have necrotizing enterocolitis, NEC in our mind, also intestinal perforation or left microcolon. Hirschsprung disease usually will present with constipation. So once whenever you finish your OPD and the parents are about to go outside, they just turn back and ask a few questions. I have tried to bring those questions to you. Can I feed water to my baby? I'm sure all of you will agree we will not feed water to baby till the baby is 4 to 6 months of age. Best preferred choice and the best for the baby is going to be breast milk, and we advise them breast milk. Unless and until there is real serious issues about breast milk, we may advise infant formulas, but we have to be very careful, and we need to explain them. In fact, few of the hospitals in metro cities, they have also started taking consent that they have been explained about the problems of infant formulas, and then they have opted for infant formulas. Till then, we make sure that baby is only on breastfeed, exclusively breastfeed for the first 6 months. Weaning can be started after 6 months. Next, should I wake the baby up for every feeding? My baby sleeps for 2 to 3 hours or sometimes more than that. For the first 1 month, we should feed the baby at least every 3 hours. We should tell them at least 2 to 3 hours, so they end up they'll not wake up every 2 hours because they also need to have rest. So they will wake up at around 3 hours or so. So if the baby is, to be very clear, at 3 hours they have to wake the baby and feed. Sometimes I tell them that not to wake the baby, just take the baby to the breast, baby will start sucking, but the baby need not be woken up. And excessive sleeping, we need to be careful if the baby is lethargic or there's any other problem. If the baby is well fed and sleeping well, we need not disturb the baby. Then next is burping. My baby is taking a longer time for burping. You need not worry about it. Some babies do not burp early, but at least you need to tell them that 8 to 10 minutes of burping is needed. And usually breastfed babies do not swallow much air. So this should not be a problem. So coming to the last thing, weight gain. Is my baby's gain adequate? So you need to know that if the baby is gaining 20 grams per day, it is absolutely normal. And in the first 10 days also, if the baby is abnormal, losing more than 10% of weight, or preterms losing more than 15% of their weight, that is the time we need to be careful. We need to rule out dehydration and infection. So we'll evaluate about feeding, urine output, and signs of infection. So after all this of explanation, there are few parents who will say, thank you, doctor. So I also thank everyone for listening patiently to me. I know this topic could have been more fun, but because of the time and the amount of slides, I have just concluded here. Thank you very much. Prashant sir.
Thank you, Dr. Suhail Ambi. In fact, you have made it very kind of very interesting and very engaging. Fantastic. First of all, a big thank you for making this topic so beautiful and so colorful. Each and every slide, there is a lot of color. The initial slide which you had put about the common OPD problems of babies, peeing, that's really wonderful. That shows that how much effort you have put to prepare this. I think this is something which needs a lot of effort to create the slide. Thank you very much for that. Now I request Dr. Raghavendra, our moderator for today, to take over the session for discussion. Over to you, Dr. Raghavendra.
Yeah, thank you, Prashant. Hello. Yeah, that was an excellent presentation by both of our speakers, Dr. Shridevi and Dr. Suhail. So that was an excellent presentation. So I just want to discuss, take some few more questions which are frequently asked. Okay, coming to Dr. Suhail. Hello, can you hear me, Dr. Suhail? Yeah.
Yeah, we can hear you. Go ahead.
Yeah, in OPD practice, when you recommend when you admit a baby in your OPD practice. Soil?
Yeah, pardon, can you repeat again? Sorry.
Yeah, when you are going to admit a baby in your common OPD practice.
Okay. As I said initially, when I show the slide, the danger signs, and if any of the danger signs is present and we are not able to treat on OPD basis, and whenever feel, as I said, whenever, even if it is benign, like breastfeeding, jaundice also, we need to admit the baby. We need to have high index of suspicion, and we need to be very clear about explaining to the parents and the need for an ICU. Even the slightest of doubt, because the newborns deteriorate very fast, we need to be very prompt and very early in treatment.
Yes. Yeah, mother comes to our OPD with frequent asking like whether I can go with Woodward's drops. So what is your recommendation?
No, I would not recommend Woodward starts. As I said earlier, the crying of the baby 90% of the times is hunger cry. So we usually you ask leading questions regarding the feeding of the child, and you'll see that there's some issue with the feeding. You just counsel them and reassure them that the baby is going to be that. Things will be helpful. In case if the baby is really having colic, we use semithicone drops, which breaks down the gas in the tummy, so the baby feels better with that. But no to gripe water.
Okay. And again, one more question. Like frequently during your first visit to your OPD after post delivery, so what are the things you will take care? Like what are the advice you give to the mother for your the next visit? Can you hear me?
Yeah, I can hear you.
Yeah, so yeah. What are the advices you will give to the mother during their first visit to the OPD post birth?
Yeah. See, whenever there's a first follow-up after birth, for the baby, we need to be clear about and knowing the urine output and motions. Like if the baby is passing urine nicely, feeding well. As I said, I will tell what a well baby is. That is the reason I put the slide earlier on. I'll tell what a well baby is, and any deviation from the well baby thing which the mother thinks, I'll ask her to report it immediately.
Are you recommending to follow the growth chart when you are you going to explain about the growth chart when during the visit?
No, I'll not explain them about the growth chart, but I'll tell them that I'll tell them about the weight. I'll tell them about the weight, and I'll tell them that I'll be monitoring growth on the chart, and it is very important that you follow up at least every monthly in the first 6 months to see for the growth, because the baby will be completely on breastfeed, and we need to see that the mother is doing correctly.
Any breastfeeding practices you are going to explain? A breastfeeding.
Sorry, I didn't get the question.
Yeah, regarding the breastfeeding technique, also you are going to explain in your first visit.
Yes, I asked a few leading questions like if she has any nipple pain, or is the baby not consolable after feeding, and if these things are there, then there's definitely some issue with the feeding.
Okay. What about? That is very important. And one more thing is regarding jaundice. What are the things if some mothers come to our OPD and asking like whether sunlight exposure is it required for treating the baby? That's what. What is your advice for them?
Sunlight exposure, see, because of the African nations, now even sunlight has gained mention in the latest Fluharty also. But the problem is maintaining the temperature and causing a burn injury thing. So if you can explain them that they can take care of the temperature and the baby doesn't harm the baby, we can probably ask them. But it is not recommended for every baby.
Okay. And any recommendations you are going to? Mother will be more anxious. She will be asking about what are the bathing techniques and massaging techniques. Are you going to explain?
Gentle massage and a strict no to oil in any of the orifices, be it nose, mouth, or this thing, ears, and warm the baby immediately post bath as early as possible.
Okay. So, Suhail, these are some small few questions which I need to highlight it. You have already extensively you have explained everything in your slides. It was very colorful slides, and thank you for those. Really, we enjoyed your slides. Thank you. So, coming to Dr. Shridevi, madam,
yes,
are you?
Yes.
Yeah.
Yes, sir. Yeah.
Madam, that was a very beautiful talk. You have covered all the birth injuries. Just few questions, madam. See how to counsel the relatives if there is any birth trauma in the labor room or like in NICU or NICU. What are the things we should take care during counseling? That's what I need to ask.
So, as I've already mentioned, that some birth traumas are like some are life-threatening and some are not life-threatening. So these non-life-threatening like lacerations and petechiae, bruises, and all. We can tell them that they are inevitable sometimes because of the presentation of the baby. So we have to explain them the natural course of the the lesion, whatever has happened, and then these non-life threatening, they need not worry, and we have to reassure them. But there are some injuries like brachial plexus injuries, especially the nerve injuries, where they need a monitoring. Immediate as well as long-term follow-up is required in that case. But this also involves sometimes medico-legal aspects.
Yeah.
But this is out of, I mean, I
Madam.
think that will be a separate session. I think Prashant
Madam,
sir might
no,
have
no, this is
discussed.
very
But
important when
yeah,
you are
this is
managing.
important. But things is sometimes they are not unavoidable. Even I have gone through many articles, but the medical legal aspect is very unclear. We cannot blame obstetrician or a pediatrician in that matter. It depends on the case to case basis.
Yeah, just next question was one more thing that I have frequently asked is what are the legal aspects should be taken when there is a birth trauma? So you have to put it in a writing, na? That is very important.
Yes, yes.
Explaining the relatives.
Yes,
Explaining the relatives. Yeah.
yeah, we need to do a thorough examination of the baby, because if you find one injury, there might be some other injuries. We have to put it in a paper and explain to them, because sometimes after going home, for example, like they may notice this clavicular injury and all. I mean, sorry, not clavicular injury. Sometimes these Mongolian spot, they get confused with battered baby syndrome. So we need to document Mongolian spot if present, and then some similarly, like if you have any lesions similar to that, we need to document. This is one aspect. The other aspect is like the severe life-threatening injuries. Like if they have a fracture and all, they might have they have lost blood, and they can have a shock, and they go on for resuscitation, ventilation and all. Then they might have again a long course in the hospital that has to be documented and treated.
Thank you, madam. And one more is how you are going to, whenever you are managing LGA babies or gestational diabetes baby, how you are going to take care of the birth injuries, madam?
I mean, post deliveries.
Post delivery, that's what. So we are expecting more macrosomic baby. We are expecting more injuries. Na? So how you are going to take care in your labor room?
So one is like, I mean, by history we would know that like antenatal scans would show what is the weight of the baby. So we need to be prepared for that during resuscitation. And then while during resuscitation also, we need to take care that we wouldn't cause more injury. Then once baby is delivered, thorough examination is important in that case. Like especially this macrosomia, they can have this shoulder dystocia. In that case, they can have this Erb's palsy. Then sometimes they may have these bruises.
Yeah.
So
are you going to prefer a normal delivery or a section in a macrosomic wedding?
So that like it depends on the maternal. It depends on the morbidity and also the maternal, stature and all. It depends. I mean, I think it's an obstetric call. But I have already mentioned, like if the babies who are delivered like between 4 to 4.5, there's almost twofold increase in the birth injuries. And if they are more than 4.5, almost threefold, then it increases. Like more than 5 kg, definitely they have 4 to 5 times more in the increase.
Okay. Madam, one more question is when you are going to involve the neurosurgeon in management of Erb's palsy, madam? These neural palsy.
So, initially, like that's what I said, like first month, I mean, as soon as you diagnose, initially 2-3 days we have to manage pain in the baby. Once that inflammation comes down, we have to start with the exercises, that is occupational therapy. And at the end of 1 month, if you see there is no improvement at all, or if there is a avulsion, like baby will present with a flail hand or a preganglionic injury, at that time you have to refer to a orthopedician or a neurosurgeon. And they also like the protocol is like they do a MRI to rule out avulsion injury and then nerve conduction study to know pre-ganglionic or post-ganglionic. If there is total nerve root avulsion, that's indication of cycle. Like so they do a nerve grafting or a nerve transfer.
Okay.
Otherwise, they can still wait for another 3 months and they look at the biceps recovery of motion. And at around 6 months also they do the same thing, cookie test and this towel test what I mentioned. If there is no recovery at the end of 6 months also, then they will go ahead with, even if it is incomplete, they will go ahead with surgery.
Okay. Madam, one more thing is what are the things you are going to counsel for cephalometoma baby parents
Cephalometoma is
before
subperiosteal
discharging?
collection of
Yeah.
blood. So usually it is not harmful. Like the collection of blood usually leads to hyperbiliary. This is
Ma'am, please unmute yourself.
Yeah. Go ahead, madam.
yeah. So this cephalhematoma, the baby has to be on follow-up at around 2 weeks, 3 weeks, because it is that point of time where they will have a hyperbiliary. So they may manifest with jaundice. So
Yeah,
we
madam.
need to call them on a follow-up during that time.
Okay, madam. Thank you, madam. These are some of the few questions, common questions, which we needed to highlight today. Thank you. That was a wonderful session by both of you, madam. Over to Prashant.
Yeah, thank you very much. I think the most of the common neonatal problems have been covered very comprehensively and very colorfully, in depth. Thank you very much for that. So I would like to thank everyone for joining the session today. Thank you, Dr. Shridevi. Thank you, Dr. Suhail Ambi, and our moderator, Dr. Raghavendra. Participants. We'll catch up again day after tomorrow. Bye-bye. Good night.
Thank you.
Thank you.
Yeah.
Thank you for giving this opportunity.